Madam Chair, we are live.
All righty. Very good. Sorry, Mike. Welcome, Wyoming, to the House Labor, Health, and Social Services Committee meeting this morning. We are going to be doing Senate File 53, which has been temporarily relabeled Private Ground Ambulance Service Provider Assessment Act. Started off with just ground ambulance, and we'll talk about that later. Committee, this is an interim bill. We had it just start in the Senate. As I said before, we just kind of divvy them up. It's kind of long. So Donna, I think first we'll have to, let's call roll. Sorry about that. Go ahead and call the roll, Donna.
Representative Clifford.
Here.
Representative Connolly.
Here.
Representative Flitner.
Here.
Representative Hallinan.
Excused.
Representative Ottman.
Here.
Representative Romero Martinez. Representative Stivar.
Present.
Representative Worf.
Here.
Chairman Wilson.
Here. Okay, we've got 8 here and 1 excused. Representative Romero Martinez, you may need to lean more toward your mic or something. You were very faint. I mean, I did hear you, but it was kind of faint. So just preparing you on that. And Donna, go ahead and let in the 2 Erics. Although Eric Boley is prepared to be much briefer, Eric Weatherford is an attorney and he is more lengthy. I'm going to try. What I want us to do, Representative Steyer, are you waving or are you just waving at someone? Oh, you've got your hand raised. Representative Stivar.
Is Mr. Hallinan, Timothy Hallinan, in the attendance? Is that?
Well, so far I've excused him because he wasn't here. Are you saying he's
in the attendees?
Oh, he's listed in attendees. Thank you for that.
I will promote him to a participant. Thank you.
Don't know how he didn't get in. And actually, seeing as Mr. Springer is in there, go ahead and move him in because really we should hear from agency folks first, although I think the Erics are probably more familiar with it. So. Oh, okay. So actually, while we get everybody in there, I'm going to send around an email. It's my picture version. Oh, hang on. Okay, committee, I just hit send on an illustration. You know, I taught school for 8 years. So failing a whiteboard that I can draw illustrations on, I am sending you an illustration of this bill in the very simplest form. Let me just give you the 30,000-foot view on this. Then we'll call on Mr. Springer from the agency's part. Although really, Mr. Boley and all they will explain the bill more at length. I don't know, Jesse, if you decide that you would rather follow the explanation, then stand up front as an agency, just say so. But all right, committee.
Oh, sorry, Chairman Wilson. I think I'd prefer to follow the Erics.
Okay, all right, we'll do it that way then. Okay, so. Committee, this is a process that we have done before with hospitals and nursing homes. And when you get your illustration, you can open that somewhere else. Here's the cheap version. The federal government says in their mind Well, we'll pay up to, let's just say, $50 for a something in Medicaid. They match us 50-50 with what we pay for Medicaid for services. So whether it's a hospital and nursing home, in this case, ambulance services, doesn't matter. I'm just going to call it service. So if we pay $47, the federal government matches $47, and then the provider gets the 47 plus the 47. Because in their head, the feds have said, well, we'll pay up to 50 and we're not, that's considered a gap. Okay, it's money that we're not putting in for that they would be willing to pay. So the federal government authorizes us to basically ask the providers to throw money into the pot, as it were. The providers could put in the $3. Then the feds say, oh, you have $50, which is 47 from us and 3 from them. So we'll pay you 50. And then all the 50 and the 50 goes back to the providers. So the providers have gotten back their 3 plus an additional 3 from the feds that matched their money. That's the simplest version. So I know when we first heard this to do with hospitals about 4 or 5 years ago, we're like, what? And sometimes that may still be your response. But the fact of the matter is that the federal government has set up this process and that we can do it. And it's a way for providers to have some skin in the game and to get back a little bit more reimbursement. So the ambulance folks across the state came to us last spring and said, we're going broke, basically. They've got services, especially if you think little rural areas, maybe they only got 1 ambulance. You know, they schlep all the way from Hewlett to Casper, then they haven't got anybody there in Hewlett while they're driving around. You know, a lot, volunteerism is down, as you know, just in general, you know, having to try to pay more people. So the ambulance companies are like, we need more money into the system if we're going to continue paying for having ambulance service, especially in the rural areas, but elsewhere. So that's how this came to us. So what we're doing in this kind of a lengthy bill, 18 pages, is basically authorize that to happen. Authorize the collection of the money from the providers, set up an account, authorize the Department of Health to amend the Medicaid plan so that they can ask the feds for this and disperse it. That's really all it is in the 18 pages. So does anyone want to ask me any question before I let Mr. Boley give a better explanation? And of course, Eric Weatherford is here too, but he gives the really lawyerly one, which is perhaps excessive, Mr. Weatherford, given that we have to be done by like 10 till 10. Representative Connolly.
First, thank you, Chairman Wilson. That was an incredible quick explanation. But my first is that I didn't get that email. I'm curious if anybody got it. It looks like no, people have not gotten it. So perhaps resend or.
Well, or you know what you might do is check your clutter bin, because I didn't put in a lot of verbiage below. It has an attachment, and you know, sometimes Outlook thinks, oh, it's just an attachment. It's probably someone advertising something, and they throw it in your clutter bin.
Madam Chair, I would hate to think that you're in junk, but
you know, sometimes I have seen things from the governor's office go in my clutter bin. Things from my personal home email gone into the clutter bin. I mean, I'm clutter to myself, even evidently. I sent it at 8:10.
well, I still don't have it, but I do have a couple of questions for either you or the other presenters in terms of kind of understanding whether this is an opt-in, opt-out, the Senate amendment, adding the word private all over the place, and the amount of money that is in that gap, and if that is the same from one provider to another. So those are just a couple of questions that I thought about.
Right, and I'll just give my answer, which Mr. Boley can probably refine. So the reason the Senate put private in is because, and by the way, we do need to amend it out of the title. The private providers need to be covered under this assessment system, because governmental ambulance services, like if the county runs one, they actually fall under a system called intergovernmental transfer. and they don't need the assessment because they just do it in a different accounting mechanism. So that, but it would be an everybody in. If it's an assessment, the federal government says you have to claim this from everybody. And the way that it would be collected is based, proportional to their revenues. So yeah, ambulance services can't opt out, which is why it's really key that we have all the ambulance people on board. Obviously, they're going to get more money back from this. And Kathy, I think there was a third one, which I forget what it was. You're on mute.
Me too. So I'll hang out. Maybe it will come back.
Okay, as the federal PR lady says, we'll circle back. Representative Hallinan.
Thank you, Madam Chairman. I don't know why I couldn't get on there when you called my name, but I couldn't. But I am here. And
I'm glad to see it. I excused you.
And my question is the $50 that the feds will pay, and the state would only pay 47. Why doesn't the state just pay 50? And that'll cover the $100, all of them. They won't have to have any donation by the provider.
Well, the reason for that, Representative Hallinan, is that would be an increase in our general fund expenses. And this way the providers throw the money in, but they get it back. That extra 3 that the providers put in. And if you, I wish you, I don't, is there, I'm not sure. I've not ever tried to share my screen, and I hesitate to do it now. It's a beautiful illustration. I worked very hard on it last night with Google Images and everything. And it's really simple too. Keep checking, because I don't know why from my house to your computer should take more than 10 minutes. Yeah, so that's the thing, is that the 3, and again, this is just our example, the 3 that the providers throw in, the Fed will end up getting 6 back, because their own 3 plus 3 from the feds. So they end up ahead, but you're right. It is kind of a monkey game. Like the feds have allowed it, and it gives them more money. That it's not a purist kind of thing. If you're into purity of approach, maybe it's not for you. But if you're into providing money for ambulance services, it's a good thing. Okay, any other over 30,000 foot questions before I let Mr. Boley talk? He knows it far better than I'm sure. Mr. Boley, clean me up.
Good morning, Madam Chairman, committee members. Eric Boley with Wyoming Hospital Association. And I also just want you to know, I serve on the Governor's EMS Council. And so I've been able to hear a lot about what's going on across our state when it comes to EMS services. If it's all right, I'll also let Eric Weatherford introduce himself now, and then we can kind of tag team this, Madam Chairman.
Mr. Boley, that's fine. But remember, Mr. Weatherford, I'm just picking on him a little bit because we don't want to hear about every syllable of it, because we won't finish in time. So I have kind of a personal list of the things that I think are high end. I did ship it to Mr. Boley and maybe he's shared it with you. I don't know, but welcome, Mr. Weatherford. Thank you.
Thank you,
I'm
Madam
just picking
Chairman.
on you because I can.
I will. I can deal with it. And thank you, Madam Chairman. Yes, I'm Eric Weatherford. I'm an attorney in Dallas, so I hope you won't hold that against me. But I will go through this as quickly as I can. And Madam Chairman, I did receive the points you wanted me to hit.
Okay, and Representative Hallinan, your hand is still up. Do you have another question?
No.
Okay. All right, very good.
All right, I'll dive in, Madam Chairman.
Put your hand down, or maybe I can put it down.
No.
Yeah, I don't see the hand feature. It doesn't seem to show. I guess I'm not a host, so Donna will have to put his hand down. Okay. All right, go ahead, Eric. Either Eric.
I'll go ahead, Madam Chairman.
Okay.
Members, I'm grateful to be before you today, and just want you to know that I sounded really good in my sleep last night testifying, my wife said, and I thought I sounded pretty good in the shower this morning too. So we'll see how this goes. And I'll just preface this with, I grew up with 2 Erics, so there were 3 of us in our neighborhood, and we were the 3 terrors. So you're lucky to only have 2 of us to deal with today. Senate File 53 is something that EMS services all across the state need and they want. We've worked closely with the EMS Association, and this is actually 2.5 years in the making as we've been trying to put this together. Just for a teeny bit of background so that you can understand where I'm coming from. I was the hospital CEO at South Lincoln Medical Center in Kemmer for 20 years. And while I was there, we had 3 EMS services. We had one in a small community called Cokeville, a community of 500. We also serviced the Kemmer Diamondville area. And then we had a service up in LaBarge, which was 50 something miles from Kemmer, and it was another small town. So I'm intimately aware of how difficult it is to keep those services operating and running. And all of those were done on a voluntary basis. And we have a lot of services like those around the state. And as Chairman Wilson indicated, volunteerism is really declining. Our ability to provide services, EMS services, is becoming much more difficult with each passing day. The issues that are facing our state are not unlike other rural communities, and provider assessments like we're proposing here have been used in multiple other states, and that's where Mr. Weatherford comes in. He has great knowledge of other programs that have been stood up in other states. Unlike other services, law enforcement, fire, EMS services are not considered a necessary service. And so while the counties may provide law enforcement and fire, the way EMS services are provided around the state varies by each individual community. And some counties are involved, some are not. There are private services, there are public services. And one of the reasons that we had to amend the bill, we needed to break those 2 types of services out because there are different mechanisms in place for how the assessment is done. And to clarify, we'll go through this, but private services are treated differently than public services. And so that's why we had to amend the bill so that we could clearly define private versus public. So I think that kind of answers some of Representative Connolly's questions. As in many other healthcare businesses, EMS is a model that is very difficult. We have EMS service or EMS calls where our EMS services are deployed to go help transfer a patient from their couch to their bed or from the commode to their bed. And there is no way to bill for that. That happens every day in all of our small communities. We also never know when the EMS services arrive on scene whether or not the patient will accept transfer. And if they don't, there's no way to bill for that. We don't know if they have insurance or don't have insurance. And so unlike many businesses where you know you're going to get paid when somebody walks through the door and you make a sale, in healthcare, you never know what that looks like. As the budget crisis has happened in our state, we've seen our reimbursement rates continue to decline. 2 years ago, there were cuts to the Medicaid programs in our state at $90 million. But if you look at the illustration that Chairman Wilson sent out to you, it actually was $135 million in cuts because we lost not only the $90 million that was cut from the general fund or the Medicaid program, we lost $45 million in Medicaid matching funds from the federal government. To Representative Hallinan's question, you are 100% right. If the state out of general fund paid the maximum they could for these services, we would receive the maximum matching amount. We wouldn't have to do these programs. Unfortunately, instead of increasing the rates that these EMS services are getting paid, we're decreasing them. We just faced another 2.5% cut, which equates to a 5% cut, and there's another one on the horizon. So the rates actually continue to decline. in EMS services, and I won't spend a lot of time on this, but EMS services are a vital part of what goes on in our state. And some of you probably heard of the golden hour, but when the person has a heart attack or a stroke, there is a 60-minute time period that's been determined that is critical to get care and help to those people. As these EMS services around the state close and as the services continue to decline, that golden hour is lost and we have worse outcomes for our patients. I will tell you that there are services that are closing all around the state. I just heard yesterday up in the northeast corner, an EMS service is planning on closing. Just recently in the Sweetwater County area, the county decided they could no longer afford the contract they had for EMS services. And so they've stopped that contract. And now that Sweetwater County is trying to figure out how they're going to provide EMS services. We've seen small services close all across the state. And those are just examples. I think you'll hear later up in Bighorn Basin, there's a lot of consolidation and things going on, but they've had services that have really struggled. And so we've got some partners working up there, but again, it comes at a cost. There was a recent example in Sublette County where on a weekend, there were multiple calls and there wasn't enough EMS service to take care of all the patients. And I could go on and on about the issues that EMS services face all across our state and also how important those services are. For our Medicaid patients that we take care of, we normally see about a 30 to 40% loss on each of those runs. And so the amount that we actually get paid for those particular patients, it's done at a loss. And what this particular program would allow us to do would be, it would allow us to assess ourselves and draw additional federal funds in to help decrease the amount of money we lose on every one of our Medicaid runs. It's not going to fix it. It won't cover the entire amount. This is actually, and I've used this analogy before, this is actually a Band-Aid on a gaping wound that needs a tourniquet, but at least it would allow a little bit of relief. I would tell you that an ambulance alone right now costs somewhere in the neighborhood of $150,000, and that's just to purchase it, let alone to put supplies and equipment in it. And then as in every other business, the employment costs are high. We're seeing more and more where paramedics are needed and where full-time staff is needed, but that comes at a huge cost. And it's a fixed cost where you have people that are sitting idle for a period of time, waiting for those calls to happen, but it's necessary. It's just like staffing an emergency room in a hospital or other services. You never know if those patients are going to be there, but you expect you expect professionals to be there when they're needed. And that's the business model here. You could have an ambulance service sit idle for most of the day, and then all of a sudden there's an emergency and someone's broken their femur in a snowmobile accident up in the mountains, or you've had an explosion out in the oil fields, and you expect EMS to be there at the drop of a hat.
Mr. Boley, if I can pause you there for a moment, I see Representative Connolly has a question.
Thanks, Madam Chair. Mr. Boley, one of the questions I had with reading it, and forgive my ignorance and being new to the committee, but I was curious if it's relevant if your patient is has health insurance, is private pay, is Medicaid or Medicare. Does that make a difference in terms of how we think about the scenarios that you just laid out and then that federal reimbursement?
Mr. Boley.
Madam Chairman, Representative Colley, I think I understand what you're asking me. So this is strictly based off of what we could be paid and what we are paid for Medicaid patients. Although what we do receive in reimbursement from all payers kind of goes into how we calculate what the assessment should be to help us figure out what needs to be assessed for each of the different services. Does that answer your question?
Thank you, Madam Chair. Follow up. That starts to, could you tell us in general, what percentage of your patients are Medicaid patients?
Mr. Boley.
Madam Chairman, Representative Connolly, that's a good question. And I think it varies by geographical location. And I I could take an educated guess, but I would, but it wouldn't be exact. I would expect that. Yeah, I'm not even sure I dare do it, but
Oops. Okay.
Representative Connolly.
Yeah, thank you, Madam Chair. And Mr. Bowley, I think just because I think it's relevant and it will be relevant to the floor, I think sometimes it surprises people how many people in the state are on Medicaid or Medicare. That, for example, I think it's like 30% of births in Wyoming are to moms who receive Medicaid. That's a relevant piece of information that I think most people don't know. So if you could kind of get that for us, I think that could help. And I do understand that it would differ from provider to provider, neighborhood to neighborhood, or whatever, but it would be relevant, I think. Thank you.
Thank you. I would think that it would probably really be real varied. I mean, I could hypothesize that it would probably go from 20% to 70%. I mean, I'm just sort of shooting from the hip there. And by the way, it's half of the births in Wyoming are Medicaid.
Yeah, okay.
Just so you know. But while we've paused there just for a moment, Eric, do you have a figure? How many ambulance services do we have? How many private and how many public?
Madam Chairman, I think we have about 68 services, and I think there's probably about 25 that are private, and the rest would be public. And I also just received a text message from people who know a lot more than I do. The answer to Representative Connolly's question is typically it's 20 to 30% of Medicaid.
Great, thank you. That was good and fast. But just to confirm, so Mr. Bowley, the total is 68 services, and so about 25 private and about 43 public. That's correct? That was within the 68. And I realize you might be off by one or two, but
Madam Chairman, I think that's pretty close.
Okay.
Eric might know better than me. We've done some modeling.
great. Representative Hallinan.
Thank you, Madam Chairman. Mr. Bowling, how about the patients that don't have any insurance and are not on Medicaid? How does that affect the assessment? Because those people aren't going to be paying you anything, probably.
Mr. Bowley.
Madam Chairman, Representative Helen, great question. It's similar to what hospitals and others face, is we just don't get paid for it. It would be a write-off. And so it doesn't really impact the calculations here, but again, it helps to put that Band-Aid on that gaping wound.
Right. So the issue, the committee, in this bill, the only thing that we would be affecting is the Medicaid reimbursement. It's not ways to get more money from insured people or uninsured people or some other source. So let's call it 30% of the patients who are Medicaid, the ambulance providers would get a slightly higher reimbursement for those people. Doesn't affect what they get for the other ones, but it does put more money into the system. You know, if as an ambulance company, you've made, let's say, an extra $2,000 a month, then that just means you are more able to buy supplies or whatever to restock your ambulance for everybody's use. I'm just picking numbers, but I think I saw Representative Stivar was hand up. No? Okay, not. You know, Representative Stivar, you might have a career as some sort of a football ref. I'm not sure. I played basketball in high school, and I always think that this means traveling, and it means something different in football, and I'm not really sure what it means in the Stivar sport world, so you might have to. Okay, go ahead, Mr. Bowley.
I think he's telling us to slide into second, Madam Chairman.
Okay, well, okay.
So just another correction, Madam Chairman. I think there's only about a dozen of the 68 services that are private.
Okay.
And with that said, that's kind of the basis for this. I will let you know that we've had multiple calls. We've worked with the EMS Association, had multiple calls educating them on how this looks. And we haven't received any pushback. That realistically, it's not going to be a lot of money, but when you have a small service that's floundering and can barely make payroll, even if you get $20,000 or $30,000 a year, that could change things drastically for them. And so this isn't a lot of money. The footnote, the budget footnote, we'll go through it, but you'll see it's, I think, $2.7 million, which only half of that is what the assessment will be. That's the net, that's the total benefit. So it's about $1.5 million that would be distributed across the 68 services. And of course, the bigger services would probably benefit more, but the small services would still get a proportional benefit. The other thing that we found as we've gone through this is there are certain services that don't do any billing at all, and they're totally supported by some form of funding. What we would hope is that maybe this would encourage them to start doing that, so they could see some benefit that way as well. But we found in a lot of small communities, it's really difficult. There's a lot of expertise that's needed to bill properly. Facilities that are associated or affiliated with hospitals, they're able to bill differently than the standalones. And so there's a lot of nuances, but our intent here is to try and help as many of these services as we can to at least have a little bit more financial stability and viability.
So, and I see Representative Worf's hand, but let me just ask before I forget, I don't seem to have had enough coffee yet. So Mr. Boley, if there's only 12 that are private, they will be the participants in the assessment, but my understanding is that the public entities would basically pay the equivalent amount of an assessment, just they won't be formally assessed. They will just be agreeing to pay through intergovernmental transfer their proportionate amount. Is that correct?
So Madam Chairman, and we can talk about this as we go through the bill, but the private entities, the way that CMS, and CMS is the top dog on this, that's the Centers for Medicare and Medicaid Services with the federal government. Anything we do is going to have to be approved by them. And so the other programs we've done like this, we've had to work with them and submit a state plan amendment to them that they can either approve or disapprove, ask us questions, and it's quite a process. But the reason that we had to differentiate and amend the bill is for private entities, it's a broad-based, all-in approach. So all of the privates would have to participate, would have to pay the assessment. For the non-state-owned governmental entities, it's a voluntary thing, and they use intergovernmental transfers because it's already government money that they have. So it's just a different mechanism, but there is a differentiation. So the privates all have to participate, whereas the publics, the non-state-owned governmental entities, they can do it voluntarily. And it, depending on what we do, so we could do two things here. We could do an upper payment limit program.
Well, let's just stick with what we're doing in this bill, because I know we talked about other options, and I think that's too complex to go now. But just
Okay.
if the publicly owned ones don't put in, do they still get a higher Medicaid rate, or in this bill? No.
Madam Chairman, if we are able to get the state plan amendment approved, they would all have to. There's not an option for them, and that's where Jesse and the Department of Health would come in, is that they would have to pay the assessment.
No, I'm talking about the publicly owned ones.
Oh, I'm sorry. The publicly ones can opt in or out.
But
And
do they still benefit from the Medicaid reimbursement even if they didn't pay in?
no, Madam Chairman, and that might be the reason that they would do it. If they're not billing anybody, there's no reason for them to do it. So under the public portion of that, the reason they would do that is because they are billing Medicaid and they want to see an enhanced reimbursement.
Okay, thank you for waiting, Representative Worf. Sorry. Yep, you're muted. There you go.
Thank you, Madam Chair. I appreciate it. No problem. I mean, I think it's been a great discussion. One of my concerns is I sat and listened to this, having came out of the nonprofit sector, one of my fears in the back of my head has always been, I see the government doling out more and more money, and I see the federal deficit just growing out of control. And I know that these are unique times with all the COVID stuff going on, But I really, I guess I'm concerned. I see as we see government step up and you know, Mr. Boley kind of touched on this, as we see the government stepping in and bearing a lot of this burden, we're putting more and more at risk. And I see the nonprofit organizations that have rallied around and supported EMTs and supported all this stuff, they're going to be pushed out of the way. And we're going to be left with the government system that we're dependent on. And when it collapses, how do we get all this back? And I guess that's the concern I see. We're creating all kinds of disincentives for people to roll up their sleeves and be creative in their own communities to solve these problems. And I think it's to me, we're losing that independence that we've always had as a nation. And I don't see the younger generation stepping up to the plate. And I'm worried that as we continue to replace a lot of the incentives for our local communities to really be engaged and participating in the things that matter in our own communities, and we turn it over to a big government bureaucracy that doesn't give two spits about one of us, when this thing collapses, how do we rebuild it? And I guess that's the only concern I have. I think it's great that we help those that are struggling, but I also wonder what kind of incentive does that give those in the private sector if they think that, you know, they're going to be bailed out? They don't need to be responsible. And I have no doubt, I have lots of friends that are EMTs that don't get a dime. They do it purely because they love their community and they love serving the people that they work with, that they communicate with, that they just rub shoulders with. And that's my biggest concern with this is I just, there's some trepidation that I have that we're all putting our hands out. And I think sometimes we're better off under the current system where we go take care of ourselves. And so I don't know that there's a question other than, is that not a concern to Mr. Boley and the committee? I guess that's something I'm going to throw out to everybody. Thank you, Madam Chair.
Mr.
Ma'am.
Boley.
Madam Chairman, Representative Worf, I think it's a great question. I think it's definitely a good conversation to have. I think the thing that I would say is we're not taking care of the problem. We continue to cut budgets and we're seeing services fail all across the state. The fact that we're asking for additional federal funds, it's actually funds that are due to us. If we were to pay appropriately through the state budget, which we can't do, that money would come to us, and it's part of what's budgeted and it's part of the program. So what we're trying to do is just find a way to access funds that are already set aside to pay for these services. I do agree with you that there are concerns that if these programs go away, we're going to have to look at other things. But what I'm trying to do and what we're trying to do is to avoid losing these services altogether in our communities, and it's happening all around us. It's not as apparent in some of our larger communities, but even those services are struggling mightily. But in the small rural communities, it's unbelievable the pressures that they're under and actually the risk we're putting our citizens at because we just don't have enough services and the ability to provide those.
Okay, Eric, I see Representative Hallinan.
Thank you, Madam Chairman. Mr. Bowling. So the Medicaid payment is abysmally low for these services. Is that correct? And can't they solve the problem at the federal level just by raising that upper limit level?
Mr. Boley.
Madam Chairman, Representative Hamlin, it's a good question. I wouldn't say it's abysmally low, but it's lower than what our actual costs are. And so the federal government has put a cap that we're nowhere close to, and it's all driven by what the state pays. And so, you know, they could raise the cap, that's fine. But if the way that federal funds work is it's a 50-50 match. And so for every dollar we put in, we get an additional dollar back. And so if we're not putting that dollar in, we're not going to get the money back. That illustration that, I don't know if you got it, but the illustration that Chairman Wilson sent out, it's a really good example of how this works. But we could take care of this. We wouldn't need to do this if the state could pay more. We could draw down more federal funds, but our budget doesn't allow us to do that. We actually continue to cut. I don't know. Does that answer your question, Representative Hallinan?
Representative Hallinan?
Thank you, Madam Chairman. And Mr. Bowley, yes, I believe that does. It's kind of, I don't know, it's kind of a mess, isn't it?
Madam Chairman.
Welcome to the Representative Hallinan. You've been on Labor Committee for a while now. Why do you sound surprised?
Well, and Madam Chairman, Representative Hallinan, in your practice as a physician, you saw the same thing when it came to different types of payers. But in this particular case, these EMS services don't know what they're going to encounter when they go to each call. And so it's even a little bit tougher for them.
Representative Ottman, did I see you preparing to raise your hand, or are you just readjusting? Okay, committee, let's go ahead and let Mr. Weatherford kind of go through some of the specifics on the bill. We'll certainly want to have more questions, I'm sure, but we may as well at least do our diligence of looking at the pages. I sent out to the Erics earlier sort of a summary of what I thought the main page areas were. You know, in any bill, you've always got a lot of, I don't want to call it extra verbiage, not to disrespect to the legal work that goes into this, but as far as conceptually understanding what we're doing, I picked a number of pages that I think are the meat of what we're trying to get at. And just to remind folks, we should really work off the engrossed copy. Before we just get started, the differences between the introduced copy and the engrossed are basically just two things. One is they inserted the word private before ground ambulance throughout to clarify that the assessment only goes to the private side and not the public. I will, if we move this forward, I will move to delete the insertion of private in the catch title, right at the very top of page. That one actually shouldn't be there, but all the rest is private. And then on page 8, the very last page, well, actually we've got pages 18 and 19 now. There are 2 additional paragraphs that were put in, it really having to do with talking about the provider, what the Department of Health can do. And we'll come to that when we get there. But other than that, but still, just so that we're all on the same pages, you probably want to work off your engrossed copy. Okay, Mr. Weatherford.
Chairman, Madam Chairman, thank you very much. I'll try to get through this as quickly as I can. And I do want to give a quick heads up that both my kids and I are all online at the same time because we're all in quarantine. So our video feed is a little choppy, so I apologize in advance. I don't think I have a copy of the engrossed version, but I can go by section number if that will work for you, and we can go from there.
Yeah, if there's a miss, it's not off by a lot. So committee members, if it seems confusing, I'll just interject any change. Go ahead, Mr. Weatherford.
Madam Chairman, page 3, with respect to the private ground ambulance service providers, we talked a little bit about that already. The main reason I would say that we're including this in the bill as just being private is frankly because it's simpler. We could include publics and assess them, but we have 68 total providers, whereas we have somewhere around 12 private providers. And I'm a big fan of keeping things as simple as we can. And if the publics can make their own transfers through the intergovernmental transfer mechanism, let's allow them to do that. That's simpler than assessing them. This way, we've only got 12-ish that we have to assess. I say 12-ish because there are a few what they're called corporate providers that are owned by public entities. So I think we're going to be able to shift them into the public pool. So that's why I'm saying 12-ish. Okay. So that's why it only applies to the private providers.
And let me just interject there, committee. The word ground is in there, just to clarify that we're not addressing air ambulance, which some of you may remember was a big kerfuffle in the last few years. We're not dealing with air ambulance. By federal regulation. We cannot regulate air ambulance, and that's not part of the discussion. Just pointing out that word. Okay, continue, Mr. Weatherford.
Madam Chairman, again, public providers have their own funds. You also asked about the upper payment limit. That is a federal maximum on the amount that states can pay their providers under Medicaid.
Committee, we're on page 4, picking up about line 16.
Page 4. Now, in some cases, there is a hard cap that's set by regulation. In some cases, we know that CMS, Centers for Medicare and Medicaid Services, will just impose one. This is one where we know they will impose one, and typically it's based on the average commercial rates or the Medicare aggregate rates that these providers would receive. But it's not a regulatory standard. It's just one we know that is their general practice. So regardless, there's still going to be an upper payment limit that'll be calculated by, well, frankly, it's by the state's contractor, and then the feds will approve it. The difference or the gap between the UPL is basically you take your regular Medicaid payments and then you take your upper payment limit, the calculated amount, and that difference is the amount that we could get in additional Medicaid payments. There was a question from, I think it was, and I think it might have been Representative Ottman. I'm not sure. I apologize. It's been a few minutes, on whether every provider has the same gap. That's not the case. It just depends on their utilization. And one of the reasons we are looking at multiple ways to skin this cat and to use this money. So what we're going to do is look to create a program that makes the most sense for the providers. So is there any question about the upper payment limit or the upper payment limit gap at this point? All right. Moving to page 5, the creation of the assessment account. This is just a bank account that the state owns, and it takes these assessments from all the private providers. It also collects the monies that it draws down from the feds, and then it will pay out these monies to the private providers. And now, if there are refunds that have to be paid to private providers because they over assess, or there are refunds that have to be paid to the state, or excuse me, to the feds, it will be used for that as well. But that's effectively what it's used for, is to collect and then pay out. That before we do any of that, and we'll get to it in a second, we've got to address just setting up the program itself. And so I'll get to that in just a moment, but I do want to set the table that before we even assess, we'll create this account, but creating the account all it does is create a bank account. Just like you and me, when we go into a bank, we can put our name on an account, but we got to put money into it. We can create this account, but the first thing we have to do, or to make it, matter, we got to come up with our program. So, any questions about the assessment account creation itself? And that's from section 103 and page 5.
Representative Hallinan.
Thank you, Madam Chairman. This is not strictly about the assessment account. The amount that the feds at the upper limit normal is only paid if the state matches it, right? So the provider would receive double whatever the upper limit normal is. Is that right? With the upper limit normal plus the state amount. So they would receive double the amount of the upper limit normal. Is that correct?
Mr. Weatherford.
Madam Chairman, Representative Hallinan, no, the upper payment limit is the total. So it's both it's the total of both the federal and the state share.
In other words, the $100 in my $50 and $50, the upper payment. So I guess perhaps my picture was not totally pure in that case. But they're getting 50% from the state and 50% from the feds.
Right.
So Madam Chairman, Representative Hallinan, so there's only a maximum amount that we can get through any of these programs. But I think to answer your question, in theory, whatever the EMS provider puts in as additional matching fund, they'll receive that money back plus the same amount in federal matching funds, dollar for dollar. Theoretically, there are a few ambiances, and we're going to talk a little bit about that as far as the budget is concerned, but we can never go above we'll never go above what the cap is. We'll never go above the upper payment limit. That's part of the state plan amendment that we have to file with CMS and have them approve.
But the provider will double their money.
On the assessed portion.
Right. Representative Hallinan, follow up.
I still don't understand how the state is matching the Fed dollar for dollar without the state money being equal to the upper limit. Then how doesn't that double the amount of money that they get, the state plus the feds?
So Representative Hallinan, have you received yet my little picture?
I don't think so. I'll look.
So I tried to illustrate it. If the state puts in $47 and the ambulance company puts in $3,
No.
then the feds will put in $50 because they got 47 plus 3. The feds will put in 50. So then there's a total of 100 that will be used to pay for this patient's expenditures, 3 of which the provider put in and they're getting their 3 back, plus the state's 47 and the federal government's 50. Does that make sense?
Yeah, it does. So they get double the amount of that upper limit. They get the state's 47 plus the 50 plus the 3, so they get 100. So it's
And I guess what Mr. Boley is saying is that technically the upper limit is 100, 50 and 50. But
Madam Chairman, Representative Hallinan, the thing to realize too, so let's say a standard payment for an EMS run is $100, but the cost of that is $150. When we're reimbursed, the state pays $50 and the feds pay $50 and the $100 goes to the provider. But there's a $50 loss on that. And if the state were to pay $75, then the feds would pay $75 and we would cover that cost. We would be at the cap, we'd get $150. Right now, we aren't anywhere close to that. And so based on what the state pays, they pay half, the feds pay half for these services. And what we're trying to do is just to get to the cap so we cover what the actual cost is to deliver that care to those patients. Does that make more sense?
Representative Hallinan, okay, follow up again.
Madam Chairman, so the upper limit is, in that case, $150. So the state, if they paid 150 then, or 75, then they would equal that. That would be the feds would still have 75 more that they could pay. The
So
state,
the maximum, Madam Chairman, that can be paid is 150. So the state would pay 75 and the feds would pay 75 and we would be at the cap, but that doesn't happen. So if the state paid more money, we would get more federal funds and we wouldn't have to do an assessment to draw in additional funds to get us to closer to the cap.
okay, thanks.
Representative Flitner.
Madam Chairman, thank you. With regard to this section, Mr. Weatherford is speaking to under subsection D, little Romanet little I, to pay administrative expenses incurred in performing activities authorized, etc. Expenses shall not exceed a total of 3% of the aggregate assessment funds collected in the fiscal year. If you could just explain that for me, I'm not savvy in that. Thank you, Madam Chairman.
That's good. And committee, I do also notice that the bill started at 1% and the Senate raised it to 3%. So we might also hear about that. Go ahead, Mr. Weatherford.
Chairman Wilson.
Mr. Springer.
Jesse Springer with the Department of Health. If it's okay, if I can respond to this part.
I think that'd be super.
Chairman Wilson, Representative Flitner. We normally do 1% on these bills, but the 1% has traditionally been set on the hospital assessment and on the nursing home assessment, and those are much larger assessments. So there's operating costs that actually primarily we pay to actuary and accounting firms to do this work. And so running a small assessment has, not the same administration costs as those hospital or nursing home programs, but still has some significant, and so 1% generated something like $15,000. And we thought it would take about $45,000 to run this program. So 3% generates $45,000, and a lot. If we didn't increase that percentage, basically the department goes in the hole on the administrative cost of this program, and we don't have the appropriation for that at this point because we've been through a number of reductions. And so the idea, if this is going to be provider funded, they also fund the cost of running it. So that's where we got to the 1% originally, 3% in the current version, so that there wouldn't be a loss. The only percentage that we would assess would be the actual costs of the program. So we wouldn't try to make a profit or anything like that off the provider. So we would work through the actual cost of running this program up to 3%. If it ends up being 1.5%, which it may be less with fewer providers, it could be simpler. So we may end up having to retain less to run this program, but that's the thought of this admin retention. And that's present in a number of the other supplemental assessment bills. So there's a hospital private bill, nursing home statewide, nursing home. So there's a number of other bills that envision this. There's also a physician assessment that's currently under approval that for physicians that are attached to hospitals. So there's a number of similar programs that have been approved by the legislature. It's just not, none of those are currently benefiting ground ambulances.
Representative Flitner, what's that?
Madam Chairman, I just say our intent is to make this budget neutral. We don't want to impact the state budget, and we want to make sure we cover those administrative costs. These programs are really important, so that the 3% is not a problem with us, up to 3%.
Representative Flitner, did you have a follow-up?
Madam Chairman, thank you. So I guess bottom line is would the department have to hire an additional FTE for this program, or how many, if so?
Mr. Springer.
Chairman Wilson, Representative Flitner, we've been asking for a position to run these supplemental programs for a long time. We haven't received one, but we don't think this program is necessarily the straw that broke the camel's back. So we're running 5 programs at this point, and this will be the 6th. So it's not that the costs that we're expecting are primarily actuarial. we are trying to, at some point, actually to reallocate a position to do this type of function, because we have approximately, I'd have to go back through all these programs, but approximately over $100 million that runs through these type of programs for nursing homes, hospitals. When we had the physician program, which is under federal approval currently, and then if you had this program, there'd be a lot of additional funding, which is, getting the providers closer to cost coverage. But at this point, there is a part of an FTE that works on this, and it just keeps increasing to take more and more of her time. But we didn't ask for a position as part of this, but it is becoming, as more of these programs are sought out and added, there hasn't been any positions added historically. So that's just extra work that's been added to the department, and we've been absorbing it.
Representative Stiver, your hand has kind of gone up and down, but I think you were first or next anyway.
Thank you, Madam Chairman. Can everybody hear me?
Yep.
All right. Just some comments. I believe we're growing government here, which we don't need to be doing at this time. And the other question is the waiver even been submitted for this through CMS for approval?
This would be the authorization for them to submit it, I believe, Mr. Springer.
Chairman Wilson, Representative Stiver, that's correct. So we have not submitted any, and this would be called a state plan amendment. So that waiver would be, it's not really important, but this is not a waiver. This is a state plan amendment. It's just a different mechanism. But we would not submit anything until we had authorization from the legislature. So in the case of these other programs, different organizations actually sought out these additional programs, not the Department of Health. Just to be clear, usually these have been provider initiated efforts to request these programs be added by the legislature, because the additional funding, has made their industries more sustainable. But we would not submit anything until this bill passed regarding ground ambulances. So at this point, we, especially for the private assessment, there is no legal authority to do so. So the department doesn't have any authority to create this private program without the legislature acting, particularly because it's an assessment.
Do you have a follow-up, Representative Stiver?
Yes, Madam Chairman. So the question I have is then, so we're going to do this for the private, but the municipalities and the other ground ambulance services will be still getting the $47 reimbursement from Medicaid. Is that the way I'm understanding this?
And I'm just practicing the answers because it's probably be me running it on the floor, but they can do it and most likely will do it because they will benefit from it. But they make their fund transfers through intergovernmental transfers, which is a different mechanism and doesn't need to be addressed in the bill. That mechanism exists already. Jesse, am I correct in that?
Chairman Wilson, that's correct. So the last part of the bill that's in the red highlight, I'm looking at you, everyone here, instead of the bill, but it's on the last page of the bill where it's adding the authority, page 18 of the engrossed copy, where it's in 424-104B 9, where it's adding additional providers that the department can enter into intergovernmental transfer arrangements with. And right now, what we suggested was just to specify the programs that would be desired by the legislature. At this point, it's quite broad. And legally, we could create intergovernmental transfers without additional authority. But this was to specify which intergovernmental transfer programs the legislature would desire. But for the public entities, so this public entities would be municipalities, special use districts, counties. So any of those that are governmental in nature can enter into a contract with the state, and we can look at their Medicaid billing and pay them up to the Medicare rate, and they can provide the funding for the difference. And
Okay.
so in that case,
Stop
none of
there
the
for a sec,
public's,
Jesse.
yeah, okay.
Jesse, just stop for a sec. Okay, committee, we've got like 30 to 40 minutes left. If we can take the bill in order, we will probably not have to answer things all over the place. We just need to make sure we have enough time to get the testimony. We've got some ambulance companies on to work the bill. Representative Stivar, specifically to this page, do you have any more questions?
Just that I think we're growing government again. Thank you.
Thank you. Representative Ottman. Did you have a question?
Thank you, Madam Chairman. What I'll do is I'll just wait till we get through the bill, and then if it's still clear as mud, I'll ask. Thank you.
That'll probably be good. And certainly those of us who've been on Labor Committee have delved through this mud in a couple of other deals. It's a little tricky. Don't feel excessively confused, because we've all been there. Mr. Weatherford, I think we're picking up about let's see, the bottom of page 7, we've got the assessments. Page 8, the percentage of patient revenue. I think that's probably where we need to pick up.
Madam Chairman, thank you. Yes, so this is how the assessment will work. We will figure out, once we create the program, how much money from the state side that we need to pay for it. And then we assess the private providers, their percentage of it. So if we decide that the private providers will need $100 to pay for their share of these additional reimbursements under whatever program we set up, then we will do sort of a backwards calculation and say, okay, $100 equals X percentage of all of the private providers' net patient revenues. And that may not be very much. Under the hospital program, it's like 0.9% of their net patient revenues. It can't be more than 6%, and that's a federal rule. But we basically back into the assessment percentage once we figure out how much money we need to fund the program. Any questions?
I think, committee, there are a lot. If we look at pages 9, 10, 11, there's some components there about, penalties, or if the ambulance service goes out of business, what happens? We can come back to that if there are questions later, but I really just want to make sure we get the gist of it. I think picking up on page 12 talks about the kind of the requirements on the ambulance services. And this was some committee amendment during the summer. Then Senate Chairman Scott was concerned that some ambulance providers were not accepting certain payer classes. Mr. Weatherford, do you want to address that, or back to Mr. Boley on that?
Madam Chairman, I'd be happy to. The amendment was added to require as a condition of eligibility to receive any payments that are created by this assessment, that they take Medicare, Medicaid, workers' comp, and must either be in network with the big plans, those that are more than 20% of the market share, or are trying to get in network with those plans. And there's a definition of what trying to means, but basically they're making bona fide offers to get in network with those plans.
And Madam Chairman, if I might,
Mr. Boley.
That's been addressed. There was one particular large private company in our state that was in the midst of negotiations, and you should have all received a letter from them, but they've now signed a contract, and they are in network, which is a great step in the right direction for everyone. But it'll take care of some concerns in certain communities.
Okay, so then picking up, let's see. Page 15 talks about, you know, if we discontinue it, in other words, if the feds say, we don't like your plan, you know, then obviously the whole thing goes away. Page 17, let's see, page 16 talks about approval of the plan. 17, more approval of the plan. Bottom of 17, if the people have, if it's say a corporation that has multiple ambulance services, they deal with those separately. And let's just pick up on the bottom of page 18, and either Mr. Weatherford or Mr. Springer can talk about what was amended in on the bottom of page 18. And then we'll hit the fiscal note, and then we can circle back.
Madam Chairman, I'll just jump in real quick, and then I'll pass the mic to Mr. Springer. The amendment on the intergovernmental transfers, it clarifies that any of these providers can make intergovernmental transfers, which, as you know, are just wiring mechanisms from a public entity. Could be a city.
Committee, we're on page 18, picking up around line 12.
And it basically says any of these entities can take their own public funds, send them to the state to be used as the non-federal share of Medicaid payments, and those payments can be returned to them. So it's broader than just this program, because this goes into what I would call the sort of the main Medicaid funding statute rather than just this statute. And you can see it's a different section altogether, a different chapter altogether. So
Committee, you'll just see that the existing language on line 13 authorizes qualifying facilities. And the question, of course, is that an ambulance services isn't a facility. So we just expanded the language to cover their authorization for this type of program rather than just, say, a nursing home or whatever they had before. Okay, go ahead. Sorry, just trying to.
Madam Chairman, that's fine. And I just want to hit on also that that whatever program is ultimately approved on will have to have approval from from CMS. And so whether there's an intergovernmental transfer and how it works and what the calculations are and what the assessment is, that's all first conditioned on getting approval from CMS, which in and of itself is subject to getting regulatory approval here at the state level, which is subject to public discussion. So once we pass this bill, that's just authorization to start this process.
Yes, as they say when elk hunting, when the elk is down, then the work begins.
That's right. So this bill allows the state to pursue the mechanism and to fund the mechanism if we get it put in place. So thank you very much. I'll go ahead and pass the mic to Mr. Springer.
So, Mr. Springer, the fiscal note, maybe you might just touch on, and if there's anything else that you want to flesh out before we open it up again to questions.
Chairman Wilson, looking at the fiscal note, it just projected. So first part is the revenue increase. So if you're looking there, about $1.5 million, but it kind of phases over time. So we put a growth rate on it over time, assuming that it would grow. This now would be split between this assessment and intergovernmental transfers, but it really mathematically doesn't matter. So they should work out the same. And
Jesse, I
then,
did have a question there.
Sure.
Right below the first set of numbers, it refers to the Medicare upper payment limit. Is that a typo, or is it in fact a Medicare upper payment limit?
Chairman Wilson, it should be Medicare.
It is Medicare?
Okay. So the way this is working is that we can pay up to what Medicare pays, but we haven't had enough state funding to do so.
Got
So
it.
that this is letting us top them up to what Medicare pays or some other policy set by Medicare.
Got it. Okay. Thank you.
And then on the cost side, most of this will go out in 600 series, which is provider payments, with the amount shown being retained for administration of the program.
Okay. Committee, I think, you know what I would like to do, because we're going to have more questions, I think. We have two other people in the attendee list. I think they're both from ambulance companies. So I think it would be helpful to let them in and hear what they have to say, and then let them just stay in. And then we can ask our questions kind of all about. So Donna, if you would and I see you have, we've got Luke Seifert and Doug McMillan in. And Luke has shown up first. They're in his handy dandy ambulance outfit. I was like a prop. We're not allowed to use props, but it's a great prop for committee. Thank you and welcome. And just please let us know, introduce yourself first, who you're with, and tell us what you got to tell us.
Good morning. Thank you, Madam Chairman. My name is Luke Seifert. I am the EMS Director for Washakie County Ambulance Service out of Orland, Wyoming. I'm also the President of the Wyoming EMS Association. I've been here in Wyoming for 3 years. My career has been spent in emergency medical services and emergency services in general. And I appreciate the opportunity to speak to you, Madam Chairman, and to the committee today. I would first like to address these couple of questions or comments that were made from ambulance service as a whole. Again, I represent the EMS Association, which is the only organization that represents ambulance services in the state of Wyoming. And before I do that, I just want to give some kudos to Chairman Wilson for an excellent summary of this bill at the beginning. That is the best explanation I've heard so far. So thank you for providing a clear explanation. So one thing I want to address is this is not Medicaid expansion. We are not encouraging, nor will this change the number of Medicaid enrollees. In fact, if you look at the amount spent on Medicaid in the state of Wyoming, it's fluctuated over the past several years. It does not have a trending increase that's steady. So that's one thing that's important to note. In fact, I just got off of the state website looking at the amount spent from Medicaid on ground ambulance services. The other thing I would point out that was mentioned by Eric Boley is that Medicaid is not even reimbursing us our expenses. So to give you an idea of what it costs to run an ambulance service, to run an ALS ambulance service, which means your paramedics, it costs about $1.25 million per year per crew. A BLS service is around $750,000. Again, these are figures that change depending on locale. So if you transported 1,000 patients, it would cost you at $1.25 million, it would cost you $1,250 per call. Okay, but here's the deal. We don't get paid for every call we run on. And the only time we get paid because of CMS rule is if we transport patients. So let's say you transport 50%. That means that your expense per call is now $2,500 that you have to get. Okay, these are large numbers, and that's actually what it costs to run an ambulance service. So Medicaid, in fact, I pulled up off of our QuickBooks system. I've got some figures here from Medicaid. So an ALS call, meaning paramedic level, we're getting something like $298. Okay, $298 when it costs us $1,500 or more to run per call. And in my agency in particular, I can tell you that a full-time agency here would cost us $1.3 million, and it would cost us about $2,600 per call. So that means that I am getting $298 of $2,600. So when we talk about debt, I want to be very clear that the ambulance services in the state of Wyoming are brunting the debt of Medicaid and Medicare patients, period. There is nobody here coming to save us. The counties can't afford to, out of their 12 mills that's allocated under state statute, they can't pay for ambulance services. Again, I work for a county. $1.3 million isn't there. So this is not a question of, are we incurring debt? The debt is being incurred. And ambulance services are closing all over our state. In fact, my ambulance service, as much as it pains me to say, will be closing its doors no later than May 1st. Okay. We are fortunate in this area, and Doug McMillan is here, as well as sitting across from me is Philip Franklin, the EMS director for Cody Regional Health. We're fortunate that we have a hospital system that's progressive and is investing in EMS. However, that's not the case for a lot of the state. And so if Cody Regional Health was not here, our doors would close May 1st, and there would be no one to cover our calls, meaning 1,000 calls a year would go unanswered. Eric Boley also mentioned that there is no state statute that requires any political entity to provide ambulance services. That's the case for law enforcement, search and rescue, and fire. EMS is not a mandated essential service. So this is going to go back and forth until somebody is legally responsible to provide ambulance service. It's always going to be a question of who's incurring the debt, and the ball is always going to be passed back and forth until somebody steps it up and says, I am going to put EMS and the needs of my constituents first. So as far as the EMS Association goes, we support this bill. As you can tell, I'm quite passionate about this. The money has been allocated. As both Erics have stated, Medicaid has a certain limit, and Wyoming is one of the lowest states for Medicaid. We're at a 50-50 match. Other states are 75% federal, 25% state. So we're leaving money on the table. The name of the game for the state of Wyoming and the health department is maximizing the federal match. That's the priorities have always become that way. And so that's what we're asking you to do here, is to allow us to try and maximize the federal match. I understand I personally don't want our taxes to increase, but Medicaid is a tax-funded program. And until we find out a better mechanism to fund EMS, agencies will close if this does not pass. That's a simple fact. And so I would encourage you to pass this bill, and as committees have done previously, for hospitals and primary care providers, and allow us to then, once we have provided some sort of stability, again, this isn't the answer or the be all, but perhaps in the next legislative session, the Hospital Association, the EMS Association can work on a more stable long-term plan for EMS in Wyoming. But in the interim, agencies will continue to close until action is taken. So thank you, Madam Chairman and committee. I would be open to questions at this time.
Thank you, Mr. Seifert. Questions for Mr. Seifert? Representative Flitner.
Madam Chairman, thank you. And I just wondered if Mr. Seifert, if you could maybe email us those statistics that you quoted from the EMS Association, that would be helpful. Thank you, Madam Chairman.
Mr. Seifert, that's what you can, if you just email it to me, sue.wilson@wyoledge.gov, I can distribute it. sue.wilson@wyoleg.gov, and I'll send it out.
Madam Chairman, if I might ask, which specific statistics is Representative Flitner requesting?
She probably wants all the numbers that you rattled off rather rapidly.
Okay, I can do that. I will just take down my notes and put them in email format and send those.
I think that would be awesome. Representative Ottman.
Yes, thank you. Was Mr. Seifert just talking about, Madam Chairman, just talking about the public EMS, or also the personal companies that these statistics pertain to, and how it affects them? Thank you.
Mr. Seifert, so just to be clear, are you a public, a Washakie County publicly provided, or is it a private service? If you were listening in, we were talking about the differences.
Yeah, Madam Chairman, we are a public entity. We operate slightly different than other public entities. We have an ambulance enterprise account. We receive a fraction of our budget from the county general fund. Last year, 22,500. The previous year, 22,500. And so again, yeah, we are a public entity with a slightly different model.
Or questions for Mr. Seifert? Let me just ask that. And so as you're public, you might not know this, but as head of the whole EMS association, do you have a sense on what percentage of and obviously this will be really different, from Newcastle to Natrona, but roughly what percentage of an EMS services operating budget might come from private donations, fundraising type things? Any thoughts on that?
Madam Chairman, I would say it definitely depends on your locale. As far as private, as individual citizen donations, ours is not even a fraction of a percent. We have a fairly decent amount, depending on the year, that we get through local company grants, such as industry. But most of our grants are government grants, if that answers your question, Madam Chairman.
Yep, that's great. Representative Hallinan.
Thank you, Madam Chairman. Mr. Seifert, this bill would not cover your EMS service, is that correct?
Madam Chairman, Representative Hallinan, excuse me, Madam Chairman, Representative Hallinan, this would cover our agency. It's kind of a trick question there. We will be out of service, and so technically it won't cover our agency by the time it's implemented. However, the services that Cody Regional Health, if they occupy or when they provide services in this area, they are also a governmental department, since they're a hospital district, and so that will cover them. Again, the only special thing about this bill is that it specifies that ground ambulance services are required to pay. I'm sure Jesse or Eric Weatherford could provide a little more legal explanation as to that matter. But if you desire to participate in the program, then you are required to pay the assessment fee, whether that's a direct pay as this bill provides, or whether that's an intergovernmental transfer as is allowed for government agencies. So simple answer is yes, we would be covered by this bill.
Right. So there's two prongs to this bill, Representative Hallinan. The larger part of the bill is the assessment on private companies. Then we also have the couple of paragraphs that authorize the intergovernmental transfers from the public entities to the program. So that takes up less space, because that process is already functioning for other types of intergovernmental transfers. Representative Ottman.
Thank you, Madam Chairman. Just to clarify in my own mind, so with these assessments and things and the increase in federal match for Medicaid, is this to go towards services rendered and the deficit there, or is it to go for those administration costs of this program? Thank you.
Mr. Seifert.
Madam Chairman, Representative Ottman, this is to go towards services rendered. However, the bill does allow for a small percentage to cover the administrative fees that the state would incur managing the program. So the unique thing about this bill is we understand the state does not have funds to match the increase to then thereby increase the federal match. So what we're doing is the services will put forward that amount for the match and then receive the increase back from the federal government. But of that increase, if I'm incorrect, either of the Erics, I believe it's up to 3%, the state can assess the providers to manage the program. So in other words, there would be no lost revenue to the state to manage this program.
Right. 97% of the dollars will go to the ambulance providers to buy gas for their ambulance, oxygen tubing, saline bags, whatever they spend their money on. Okay, let's move on to Mr. McMillan. Guys, we're getting pretty tight in here. We can be authorized to miss the opening prayer and such like, but it would be really great to get this bill through. Mr. McMillan,
Good
thank
morning,
you for
Madam
coming.
Chairman.
If you'll just introduce yourself.
Hi, Madam Chairman. I'm Doug McMillan. I'm the CEO at Cody Regional Health. I've been the CEO here in Cody at Cody Regional Health for 24 years. I've been a CEO in rural healthcare for close to 38 years now. I've also been in Torrington, Wyoming for 5 years. I appreciate the opportunity to share some testimony on behalf of Senate File 53 and the ground ambulance provider assessment. I really appreciate hearing from Mr. Boley and Weatherford as they've shared with you the mechanics of this bill, and Mr. Seifert, who's addressed and did a great job talking about the costs and issues in EMS services in Wyoming. From my standpoint, I just want to, number one, request your support for Senate File this bill, state why I feel your support is critical, and then just share with you a little bit more what Mr. Seifert shared regarding some of the EMS changes in the Bighorn Basin. I guess to start off with, again, and maybe at a higher level, rural healthcare has significant challenges today nationally, locally in Wyoming, and those are just going to progress and get worse. We're seeing hospitals close at an increased rate. We have over the past several years. We're going to continue to see hospitals close. And I say this because we recognize this. This is something that's evident, and communities are going to be without hospitals. And again, unfortunately, I think we will see it in Wyoming within the next few years. But to essentially offset that, it's critical if we see some of our communities with hospitals close, we have to offset that with implementation of progressive EMS services. Again, sometimes I think we all take EMS services for granted. I think Eric talked about some essential services, law enforcement, fire districts, EMS services, and I think especially in rural communities, we take that for granted. We'll always have them. They've always been there, but they won't always be there. Again, as I talked about losing hospitals, as Luke very appropriately addressed, EMS services, we have lost many nationally, and we're seeing it in Wyoming. In my years in healthcare, again, it's happening in Montana right now up in the High Line. It's just scary to see a lot of these communities that are losing their EMS services. In Wyoming, we're a rural state, but actually we're a frontier state. We have large geographic distances from where our residents live. And again, I just shudder to think that a lot of our rural communities would be without progressive EMS services. And I think of communities like Shell, Tin Sleep, Shoshone, and again, some of the smaller communities. And again, I know as House members, you would not want that for your constituents or residents within Wyoming. Again, we think of EMS services kind of like a lot of things. Is it a right or is it a privilege? Right now, it's a privilege to have state-of-the-art EMS services or EMS services in general. Earlier testimony talked about what we used to take for granted. EMS services were volunteer services. The EMTs, and usually at the basic level in smaller communities, were volunteers. Many of them still are. But based on the costs that Mr. Seifert talked about, those EMS services can no longer sustain themselves based on the high costs to run EMS, decreased revenues. And again, we've talked about, again, I don't want to get into the mechanics, but the benefit of this UPL program. This is in place in many other states in the country. We've talked about Wyoming has other similar UPL legislation in hospitals, nursing homes for hospital employed physicians, which assist hospitals throughout the state. This proposed legislation will benefit, as stated, all EMS services, public and private. And again, in general, as you've heard, this UPL program will bring additional federal dollars to Wyoming. And just assist all our EMS services during these difficult times. And they're going to get a lot more difficult. The funding will benefit the patients by protecting access to care and providing critical life-saving services. And I want to keep going back to that, because without local hospitals and local healthcare, having EMS services is very important. This bill is not about, as Madam Chairman, you addressed, it's not about air ambulance. In Wyoming, so we're a frontier state where a lot of our residents live. They do have access to air ambulance, but unfortunately, that's at a cost. And unfortunately, it's also being abused in many places throughout Wyoming and the country. But EMS services are always not available. And with that, it's just critical that you recognize the importance of this legislation. As Mr. Boley addressed, again, from a cost standpoint, some may not see it as significant, but with the assessment of the 1.5 million that will be distributed through the different in 60, 63, the specific number of agencies, it is significant. It helps. In EMS services, we don't get funded to offset the cost of providing the services, as again, Mr. Seifert addressed very well. So with that, from my standpoint, working in healthcare for 38 years, and again, just from my standpoint, seeing the importance of EMS as we continue and will continue to experience a loss of local healthcare services. It needs to be offset by putting our emphasis into EMS. So with that, a little bit about what Mr. Seifert addressed, the Bighorn Basin. We are fortunate at Cody Regional Health. We have a phenomenal EMS service. Mr. Seifert talked about the ALS service, how expensive it is to run. Most rural communities staff their EMS services with either basic or intermediate EMTs. Most of them are volunteer. And unfortunately, with the cost involved, it's difficult to recruit, difficult to retain. Again, fortunately, our EMS providers still, they do it because they have a passion for helping others. And again, as I think one of the other representatives testified earlier, we all want to see that, but again, they also are doing this because it's a living, it's their profession. But Bighorn Basin. So a couple years ago in Basin, they reached out to us, their rural healthcare district. They had EMS services, but it was problematic, and they were close to losing. Actually, they were losing their EMS services in South Bighorn County. They reached out to Philip Franklin, our EMS director, to initiate discussions. And Philip did a great job working with them, addressing our interest in serving their geographic region and providing EMS services. We went in there about 2 years ago, and it's been great. It's been wonderful for our organization to be able to ensure that they have consistent EMS services. Not only have we provided it, but we've enhanced the level of EMS services. Our service, is getting back to Mr. Seifert's comment, is ALS-based, advanced life support, which means, again, why can we make it work and they could not? Again, it's based on our leadership. We have a great program. We're able to transfer more patients that are at a higher level of care than the basic EMS services could do in Basin. So with that helps eliminate a lot of air ambulance transfers, which is a lower cost to the patient and the right thing to do. We're using the right level of care. And so we did that 2 years ago, and as Mr. Seifert addressed, over the last 6 months in Washakie County, they also addressed, because of cost and recognize the difficult ability to sustain their operations based on cost. I mean, they're fortunate they have Mr. Seifert there and other wonderful staff, but again, as a county, they were no longer able to run their EMS services. We again stepped in and had discussions with them, and beginning May 1st, we look forward to partnering with Washakie County and providing ALS services there. And again, it will be at a higher level of service that we'll be able to provide to the residents of Washakie County. We've been contacted by facilities and large systems in Montana asking if we could assist them in Montana. We've been contacted by other smaller communities in Wyoming outside of our geographic region for assistance that we unfortunately cannot provide. But I guess I'd just like to summarize the importance of this bill. Again, it may not mean a lot, but it really does to all the EMS providers and those services in the state, your support of this bill, because just every little bit helps right now. So, Madam Chairman, I will stop and I'll be glad to address any questions.
I think I did see a hand, maybe it was Representative Connolly. The hand is back down, but are there questions for Mr. McMillan? By the way, committee, I have sent an email to the speaker and to the chief clerk telling them that we are still working. It's not the end of the world if we even miss the third reading consent list. That happens sometimes, and I think that it's more important, frankly, to work this bill. Mr. McMillan, I do have one question. And you can speak from your experience, but more broadly, if these smaller rural services close, like the one in Washakie, and I don't know if Luke has gone off on a call, sometimes that happens. No, he's still there. And it's taken over by you. Does that change the location of the ambulance that is dispatched? In other words, would the ambulances now be coming out of Cody Regional, and what kind of distance is that? Or do you still, are you able to, forward station somewhere? But it would seem to me that many of the things, that you're responding to a stroke or a trauma, if it takes you another 30 minutes to get there, that's not very good. What's the situation for where you're able to station the equipment?
No, Madam Chairman, great question, and I'll address it. Maybe Luke will have something to say as well, but it's a wonderful question. No, we are in Basin. I'll start with that. We have placed EMTs in Basin. They reside in Basin. All the runs are taken out of Basin. The runs and the transfers do not come from Cody Regional Health. We see it's very important that the community sees that service as a community-based service. And so with that, the feedback we're receiving from the Rural Health District Board is, again, it's working out wonderful because, again, the community still sees it as their EMS service, but at a higher level of care. So to answer your question, the staff is based in Basin, and everything comes out of Basin. With the exception, if there is a run and there's a transfer, that's where we can come in and help. We can either go down and they may take that run, and if they have a transfer, we will send an ambulance down from Cody to assist. So there's always backup, and we intend to do the same thing for Washakie. Washakie, they have Mr. Seifert, Luke there, and then other staff. Our goal is to retain as many of those that want to work for Cody Regional Health. We do expect to bring in additional EMS providers, paramedics that will live, reside, and be in Worland full time. And it's also important from an economic standpoint. Again, these are jobs. These are jobs we do not want to take out of those communities. It's important that we keep those jobs in those communities as well.
Mr. Seifert, did you have any further addition to that question?
Yes, Madam Chairman, thank you. Just as to add on to what Mr. McMillan was saying, there's a question that's come up a few times. The first one is that you brought up about where will the ambulance be dispatched from. There are standards within the state and in the nation as to what response times should be expected. And Cody Regional Health has been able to meet and exceed those standards as they have extended their services to other communities. The other is the transport destination. That's a question that comes up frequently. Does that mean that since Cody Regional Health is operating in South Bighorn and will in the future operate in Washakie County, that patients will be transported all the way to Cody? The answer is no. There are specific laws that determine where patients need to be transported. And so the wonderful thing about this is you bring jobs to the community, you transport to the local facilities, which supports their business. When there's transfers, you have a larger corporation that can accommodate the surge capacity to transfer those patients by ground, which thereby reduces the cost of healthcare. And we can go on and on about this. So it's a truly remarkable thing.
Although I will say, Mr. McMillan and Mr. Seifert, I'm sure you didn't mean this, but you're almost making it sound like if we consolidated all the EMS service in the state into one big glob, we would probably be much more efficient and care would be good. Did you mean to say that?
Madam Chairman, I think it would certainly depend on who's running that, but in the most case, probably not.
Okay, Representative Worf.
Thank you, Madam Chairman. I guess as I've listened to the debate, I guess one of the things that the way I understand this bill requires all the private ambulance services to pay the fees. And I guess one of the questions I have is, number one, once a private business has entered into this program, can they I guess, be removed from the program if they decide they don't want to belong in it anymore? And the next question I have is, if these businesses continue to go out of business, will that mean that the remaining private businesses that are in the state are going to have to pick up more of a fee to make up for those businesses that have left the state? Thank you.
And I think on that, we might need actually maybe Mr. Weatherford or Mr. Boley or somebody to respond to the specifics of the legislation. The first question I happen to know, which is it's all in. It's not an optional thing for the private members, which is why they've been very careful to make sure that everyone is in agreement. Do you want to get more money? Yes or no? And the answer is yes. But as far as how it would be redistributed if there were a lesser, I would think that the proportion would drop in any case. But one of the Erics, do you want to address that question as far as in case people went out of business and how that affects the assessment?
Madam Chairman, but either one of us can jump in. Go ahead, Eric. You take it.
Okay,
Mr. Rutherford.
Madam Chairman, you're correct. It is a universal thing. That's why we want fewer people in it, and we want to have different options for the reimbursement methodologies, and we want to get buy-in from everyone. Number two, to answer your question, if a provider goes out of business, then basically the bill provides that they carve the fiscal year up to the point at which they go out of business, and then from there forward they don't get assessed. And this only assesses ambulances. So to Representative Worf's question, no one else could be assessed. It's only licensed ground emergency medical transport.
So if some ambulance service went out of business, then the pie shrinks. So the remaining providers are only assessed for their part of the new smaller pie. They're not covering costs that would have gone to a no longer existing provider.
That's correct, Madam Chairman.
Okay. Did that answer the question, Representative Worf?
Madam Chairman, yeah, I guess it answered the question, but I guess I disagree. If those costs are all there and somebody goes out of business, it's going to cost somebody more money to cover those costs. So I guess I'm having a hard time understanding this. I didn't like the fact that the testimony we just received said that this is about buy-in. Forced participation is not buy-in in the program. So I didn't like that. I have a hard time with this. We are forcing private businesses to do something, and it may be good in the long run, but to me, I'm having a hard time, I guess, understanding them. We've had comments that the same testimony was given that we want less people in this. It sounds like to me we are trying to reduce this down to monopoly, where we got one service provider in the whole state. And I don't, to me, none of that jives with what I've seen in my personal life. I think we're much better off to have all the communities well served and lots of people doing it rather than just one. And so I'm just, none of this is jiving in my feeble mind, Madam Chairman. So I guess I'm just going to have to sit back, and I can tell you that the emails I've gotten, everybody that's in the system that doesn't have to pay this, all the established people are all supporting it. The private sector, the emails I'm getting are opposed to it. And that's, I haven't been overwhelmed with emails, but 80% of the emails I've gotten have asked me to vote against this bill, just so you know, Madam Chairman. Thank you.
I'll just take two answers on that. One, remember the money that goes into this pot is for reimbursement for services. So if an ambulance service goes out of business, let's say, and let's just suppose those patients are not there, the money that the people put in is based on their patient revenue, and the money that the federal government pays us is in response to the claims, the Medicaid claims that the ambulance service has made, transported patient X, broken leg, whatever it is. And so the money that comes out from the federal government is not spreading all over all fixed costs, because it's basically a fee-for-service type thing. Now, obviously, those patients, if your ambulance service goes out of business, someone is still going to go by and pick you up off the road. So you are perhaps a new patient for a different ambulance service. I mean, so probably the patients don't actually go away. But so that's why I think, your idea that someone else will, because it's a reimbursement based thing. The other thing I just want to say, and this is my background in healthcare administration. And I actually worked in the ER for a couple of years, not as a clinician. I was a unit clerk when I was in grad school. The thing that is different about healthcare in general, and specifically EMS type services, or generally hospitals, is that you have fixed costs. And so if in a community, if you've got two restaurants, or, you say you got a Chinese restaurant, and then someone else comes in and opens up a steakhouse, people might go out to eat twice instead of once, because they say, I like steak in addition to Chinese. But if you have an ambulance service, you've got to buy the ambulance or the airplane or the ER room or whatever it is. And it may just sit there, especially in rural areas, for days and never be used. So this is an area where the competition methodology doesn't really work because of the impact of very large fixed costs. To say that, this ambulance service with their fleet of 2 ambulances, that we would somehow drive down costs by having a second ambulance service who also has 2 ambulances. Now all 4 of the ambulances are sitting there all week. It just builds fixed costs. And so this is where this area, the economics work really differently than they do in a lot of other industries, if I can call it an industry. So that's my little healthcare thing. Looks like Mr. Seifert wants to throw something in there.
Thank you, Madam Chairman. I suppose I should clarify a statement that I made when the chairman asked about a large organization operating ambulance services. Statewide, I'm not sure that would work. However, the idea of regionalization is an effective model that is being explored by the Governor's Health Task Force, which Mr. Boley also sits on and which I sit on. That is what we are seeing with Cody Regional Health. It's a local company that is providing ambulance services in a region, and that is effective. That being said, you don't see people lining up to provide ambulance services. And so when we talk about ambulance services closing, it's not because they don't want to provide services. You can't just generate revenue because you increase your business, right? We get called and we respond to those calls. We can't go make calls. So if we're talking about the principle of how EMS is reimbursed, I would say it's wrong completely, because we're based on a call or a transport reimbursement versus on a readiness model like fire is based. So fire services receive a certain amount to be ready to respond to calls. They don't get paid per call. However, ambulance services are the exact opposite. So we have to maintain readiness, but we're only paid when we're used. So the model itself is flawed for sure. That being said, we're so far down this path now that the proper way to fix this is to decrease the debt that ambulance services are incurring by providing services to Medicare and Medicaid patients, specifically this bill addressing Medicaid. The other thing that should be noted is ambulance services don't choose who they transport or who they care for. And so, again, pertaining to this bill, if we get a 911 call, we're not a specialty surgical center that can say, can you pay or not? We are required to respond. And then, like I mentioned earlier, when you're only getting paid $300 for a call that costs you $2,500, you're incurring a debt by responding. And so, there are many, many issues to the way that EMS reimbursement works at this time. Some people have, or some organizations have figured it out, like Cody Regional Health, and because of their organization are able to provide that without losing money. But this bill specifically aims to address the system as it exists now before it collapses. And in the meantime, there are groups working on how do we stabilize this through other means.
Mr. Boley. I guess you wanted to add something. You don't get to ask questions, Mr. Boley.
Well, thank you, Madam Chairman. I just wanted to address Representative Worf quickly. So we are not in any way trying to create monopolies. We're actually trying to help services that exist and are trying to stay in existence. We have private entities that are closing. There's one in Newcastle that's closing. I already talked about what happened in Rock Springs. We're not trying to create monopolies. There was another question about, what happens if you don't have ambulances. So in South Lincoln County, the service in LaBarge had to be closed. It's 60 miles from Kimmer to LaBarge. It's an hour to respond. It's another hour to Pinedale if you go north. The small service in Cokeville, which is 50 miles from Kimmer, it's on a shoestring budget, and either you have to go from Kimmer or you've got to come over Salt Creek Pass from Afton to serve that community of 500. This is reality. We're not talking in abstracts here. This is reality. It's happening all over our state right now. The fact that you're hearing from folks surprises me. We have talked to everyone. And what I would say is what we're asking here, we're asking authority to work with CMS to come up with a plan that will work for our folks. And there's public comment that will be made before the plan is accepted. This just authorizes EMS services to help themselves. And to Representative Stivar's point, we're not growing government. We're trying to take care of obligations that these folks have. If the state would reimburse us at the level that we could maximize our federal match, we wouldn't have to do this, but that's not happening. We're getting reduced reimbursement every single year. And so we have to do this. This is a solution that we're willing to do ourselves, and that we're asking permission from you, which I wish we didn't have to do, but we are, so that we can go out and get additional funding to help with these absolutely necessary services in every corner of our state. With that, I'd answer any more questions.
Okay, committee, any last questions? And those of you who are in the chamber, I can see you're standing up. However, the committee is continuing on. I guess it would be really impolite to sit down and talk during prayer. So I grant you leave to pray and say the Pledge of Allegiance, but we are still meeting. We will all be excused, I'm sure. Okay, Representative Hallinan.
Thank you, Madam Chairman. I wonder, is that document that you have describing this bill, I haven't gotten it yet, so I don't know what it has in it. Does it have?
Representative Hallinan, are you talking about the illustration that I sent out?
Yes.
You still haven't received it?
I haven't received that.
Do you? Representative Flitner says she got it. Representative Romero Martinez says he got it. It says illustration for SF 53, and it has a little paper clip on the left side of the thing.
Okay. Well, my question is, does that document have something about how this assessment is calculated? And if it doesn't, and I presume that it probably does not, would Mr. Bowling or one of the other gentlemen that presented, one of the Erics, could they send me or you a copy of how the assessment is calculated from each one of these private ground companies? I would like to have that document to show, so I would understand how that's calculated.
Representative Hallinan, what I sent is merely an illustration with some dollar bills on it. It is not in formula in any way. The bill itself on page 8, it gives it fairly, it's still somewhat up in the air, but it says a uniform percentage of each provider's net patient revenue. The assessment rate is going to be imposed every fiscal year on a prospective basis based on the percentage of net patient revenue necessary to generate the amount not to exceed the non-federal portion of the upper payment limit gap. So in other words, they're going to take what the gap is, then they will take the number of providers and divide out and then distribute it based on proportionality of the net patient revenue. And that's what it says in the paragraph on page 8. Are you asking them to give you a sample of that? Or, I mean, and I'm not sure that it can get really more clear than that at this time, although I suppose they could give an example. Mr. Bowley or Mr. Weatherford, do you have anything to add to what my explanation there?
And Chairman, I think you hit the nail on the head, but just in terms of giving an example, let's say we determined that we wanted to put a reimbursement program in place that would generate $1 million. We would need to assess the providers in the amount of $500,000. Now, I'm not going to do the brain damage of taking out the 3% for the administrative fee, so just forgive me for that. So we would take the $5 million. Then what Mr. Springer's group does is they take all of the private providers' total net patient revenues. And that's going to be a big number, something more than the $500,000, and figure out what percentage of that total net patient revenues they need to equal $500,000.
Right. So in other words, it's a giant 9th grade algebra problem where you have, the different ambulance companies are A, B, C, D, E, and such like, and it equals $500,000. And then if ambulance A is 2% of the total, and ambulance B is 4% of the total, and ambulance C is 6% of the total, and ambulance D is 1% of the total, then you just apply those percentages to the $500,000 and back into each ambulance company's allotment. Is that right?
Madam Chairman, that's correct.
And I believe if you have one of your children there who's working on their 9th grade algebra problem for, while they're in quarantine, you could give them that assignment. Representative Hallinan, does that answer basically?
I guess I'm just not as smart as these 9th grade kids. Because I don't know where the 500,000 came from. How do you know that's the amount that you want to have it based on?
Representative Hallinan, that's the gap. The difference between what the feds are willing to pay and what they're paying now. We know what the gap is, so then we just take that out and distribute it proportionally among the participants.
Okay. All right. Thank you.
Okay. All right. Any more questions? And other than that, I would look forward to a motion on the bill. Representative Connolly.
So moved.
Moved, seconded by Clifford. Okay, any other, I do have one amendment, committee, and that is on page 1. The Senate, in their enthusiasm, put the word private all over the place and got one too many. And that is in the catch title, right under the word Senate File 53, we need to delete that word private because of the amendment on page 18 and 19. Is there a second for that amendment? seconded by Romero Martinez. Any questions about that? Okay, all in favor of that amendment, please raise up your hand. 1, 2, 3, 4, 5, 6, 7, 8. Any opposed? 1. Okay, that amendment has passed. Donna, did you get that?
Yes, I did, Madam Chair. Before we take the vote, would you like me to move members of the public back to the waiting room?
Oh, yeah, you may as well do that just so that I don't get confused and wonder why they're not voting.
Okay, give me a moment,
Goodbye. Thank
please.
you, everybody. You have been wonderful. Feel free to continue listening or to email us.
Thank you.
Okay, any other any other discussion on the bill that would be pertinent to amendments, changes, whatever, keeping in mind that it's fairly wonky of a bill. Any more discussions on the bill? Question being called. Donna, would you call the roll, please?
Are you prepared for me to take a roll call vote?
Yes, ma'am.
Madam Chair? Okay.
Go right ahead.
This is roll call vote on Senate File 53, Private Ground Ambulance Service Provider Assessment Act. Representative Clifford.
Aye.
Representative Connolly.
Aye.
Representative Flitner.
Aye.
Representative Hallinan.
Aye.
Representative Ottman.
Nay, no.
Representative Romero Martinez.
Aye.
Representative Stivar.
Representative
No.
Steyer. No.
Representative Stivar, no. Representative Worf.
Representative Worf votes no.
Chairman Wilson.
Wilson, aye.
Madam Chair, the vote is 6 aye and 3 no.
Very good. Thank you, committee. Donna, I'll stay on just a moment as you had requested. The rest of the folks can go off, and I believe the speaker has left the roll open for us. And we'll see you all again